Myself Dr. Sowmya, reader from Department of Dental Materials, Yenepoya Dental College, Yenepoya deemed to be university. Title of my today's presentation is Polymer with Antimicrobial Properties for Prosthetic Applications. SLO for today's presentation. After participating in the session, students should be able to explain the need for antimicrobial activity in PMMA denture based material, describe the strategies to combat microbial adhesion on PMMA denture based material, discuss the effect of addition of quaternary ammonium based antimicrobial monomers such as DHMAI and DDMAI on the biological properties of PMMA heat cure denture based resin. Contents of today's presentation: introduction, literature survey, aim, objectives, methodology, statistical analysis, results, discussion, conclusion, limitations of the study, scope of future work, summary and references. Coming to the introduction, in 1937, Walter Wright introduced PMMA polymethyl methacrylate denture based resin as denture based material. By 1947, worldwide 95% of the dentures were fabricated using PMMA polymeric material. PMMA based material has various biomedical applications such as intraocular lenses, bone cement in orthopedic surgery and dental prosthesis. Coming to the applications of PMMA in dentistry, this polymer is widely used for the fabrication of complete dentures, removable partial denture, maxillofacial prosthesis, denture relining, denture repair, special tray fabrication, artificial teeth, temporary crown and bridges, orthodontic retainers, occlusal splints and palatal obturators, etc. Coming to the merits of PMMA denture based material, this material has got favorable properties such as excellent biocompatibility, low insolubility in oral fluids, good aesthetic, low density and easy fabrication methods. It has got some of the drawbacks such as inferior mechanical properties, low thermal conductivity, high water absorption and solubility, possible tissue irritation or allergic reaction due to the presence of residual monomer, and finally lack of antimicrobial properties, etc. Due to the lack of antimicrobial properties PMMA material, denture bases favor the growth of Candida albicans on the denture bearing surfaces. Other species of Candida such as C. dubliniensis, C. parapsilosis, C. tropicalis, C. cruzae and C. glabrata has been isolated. C. albicans can easily proliferate through the hard and soft tissue of the oral cavity and adheres to the denture processes, forming a biofilm, which is the first step contributing to the development of denture stomatitis. Denture stomatitis is characterized by inflammation and erythema of the oral mucosa. Prevalence of DS worldwide is reported to be 65 to 70%, higher in females about 84 to 86% and higher frequency among people aged less than 50 years. DS has multifactorial etiology such as poor denture quality, nocturnal denture use about 56%, accumulation of dental plaque, low pH less than 6.5 under the denture prosthesis and finally hydrophobicity of the denture surfaces. Coming to the symptoms of DS, mucosal bleeding, paining, burning and painful sensation, unpleasant taste, swallowing difficulty, dry mouth and septicemia among immunocompromised patients. Factors influencing the Candida adhesion includes surface roughness on the denture surfaces, electrostatic interactions, hydrophobic interactions and salivary pellicle. Candida growth on denture occurs in three developmental phases: Coming to the first one, initial stage, which occurs within 11 hours from colonization, where candida cells added to the denture base surfaces and producing microcolonies. Second one is the intermediate stage, which occurs within 12 to 13 hours after colonization. Here, extracellular polymeric substances (EPS) accumulates over colonies, and the last stage is maturation stage, occurs 38 to 72 hours after colonization. Here biofilm formation is going to take place. Denture biofilm consists of dense layer of microbial communities embedded in a polymeric matrix and exhibit increased resistance to antimicrobial agent. Among Candida species, C. glabrata, C. cruzi and C. lusitania exhibit high surface adherence and shown inherent resistance to antifungal agents. Risk of Candida infection mainly seen in organ transplanted, HIV infected and chemotherapy patient, and Candida infection negatively impact their health, resulting in limited nutritional intake, resulting in some of the systemic diseases such as pulmonary candidiasis, infective endocarditis and aspiration pneumonia, thus increasing the chances of morbidity and mortality rate about 71 to 79%. Coming to the treatment of denture stomatitis, there is no gold standard treatment. The clinical treatment involves multiple approaches such as strict denture hygienic and oral hygienic measures, discourage night denture wearing, overnight soaking in disinfectant solution, usage of effervescent tablet, microwave irradiation and laser therapy, and last one, topical and systemic antifungal therapy. However, these approaches have certain drawbacks such as salivary flow in the oral cavity, washes of the topical application, and microbial resistance and adverse drug reaction associated with the prophylactic systemic antibiotics. Coming to the literature survey, strategies to combat microbial adhesion includes biocidal surface coatings, cold plasma treatment, incorporation of antimicrobial agents. Coming to the biocidal surface coating, here some of the coating agents such as 2-octyl cyanoacrylate, silica, titanium oxide, zwitteron or hydrophobic monomer, diamond-like carbon, fibrin biopolymer and punica granatum and chlorhexidine, silver nanoparticles and MPC coatings are mainly applied on the denture base surfaces to reduce the Candida adhesion. Coming to the second approach, here some of the cold plasma treatment such as ARSF6 by 70 watts, ARO2 by 70 watt treatment was done mainly to reduce the Candida adhesion. Both the approaches have lack of investigation, hence need to validate its long-term biocompatibility, antifungal efficacy and potential side effects. Third approach is incorporation of antimicrobial agents. Here there are two types of methods are followed. In the first one, physically blended antimicrobial or agent releasing type of antimicrobial agent, and the second one, copolymerizing antimicrobial agents or antimicrobial monomer. Coming to the physically blended antimicrobial agents, here antimicrobial agents such as synthetic antimicrobial agents, for example chlorhexidine, quaternary ammonium compound, food preservatives, dimethyl methacrylate monomer, zinc dimethacrylate and surface pre-reacted glass ionomer. Coming to the natural antimicrobial agents, ginger, apple cider vinegar, neem powder, henna, thymoquinone, chitosan, phytoside and caffeine. Coming to the nanoparticle based, Ag nanoparticle, titanium oxide nanoparticle and metal oxide based nanoparticle. Coming to the last one, carbon based nanoparticle, here some of the material like graphene oxide nanosheets, carbon nanotubes and graphene silver nanoparticles are physically blended with denture base material just to improve the antimicrobial activity. However, this approaches has some of the drawbacks such as reduced antimicrobial action with the time due to leaching, low efficacy rate of antifungal drugs, microbial drug resistance, tissue reactivity and adverse effect on the mechanical and physical properties of the dentures. Hence, prohibited its widespread use in dentistry. Coming to the last step approach, copolymerizing antimicrobial monomer. Such monomer are also called as copolymerizing antimicrobial monomer. This concept was introduced first time in the year 1993 by Emezato and Crow workers. They pioneered the concept of immobilized bactericides. Immobilized bactericide is a monomer that contains both an antimicrobial group and carbon-carbon double bond, which enables the grafting of antimicrobial groups onto the polymer network through chemical bonding. After copolymerization, antimicrobial agent will not be released from the dental materials, offering long-lasting antimicrobial effects. Coming to the detail about antimicrobial monomer, the first synthesized monomer is methacrylolyloxydodecyl pyridinum bromide MDPB, and later in 2004 first dental adhesive incorporated MDPB was successfully commercialized. Later few more antimicrobial monomers such as MDPB, MUPB, DMAEMA, DMA-DDM, TBAEMA, AECB, AAM etc. synthesized later, and coming to its application, these monomers are successfully utilized to impart antimicrobial activity to dental composites and bonding agents. However, its prosthetic application for application has not been widely reported. Hence, in the present study, we have selected copolymerizable antimicrobial monomers such as DHMAI and DDMAI and analyzed its suitability for prosthodontic applications. The unique property of this monomer includes copolymerization chemically with the PMMA matrix, provides long-lasting antimicrobial activity and consists of methacrylate group that immobilizes the microbes, and quaternary ammonium provides biocidal action. Finally, consists of long carbon chain length, hence superior will be the antimicrobial activity. Coming to the aim of the study, to evaluate the effect of addition of quaternary ammonium based antimicrobial monomers such as dimethyl hexadecyl methacryloxyethyl ammonium iodide DHMAI, 2-dimethyl 1-methacryloxyethyl ammonium iodine DDMAI on the biological properties of polymethyl methacrylate heat cure denture base resin. Objectives of the study includes to examine the cytotoxicity of the modified PMMA resin, to detect the antimicrobial activity of modified PMMA resin. Coming to the methodology, coming to the cytotoxic study, cytotoxicity of the test sample were investigated by methylthiazolil tetrazolium MTTSA method using L9 mouse fibroblast cells. Here 3 experiments were performed. Experiment 1, cytotoxicity evaluation of DHMAI and DDMAI. Experiment number 2, cytotoxicity evaluation of modified PMMA. Experiment number 3, cytotoxicity evaluation of modified PMMA in artificial saliva at regular interval of time, 1 day, 1 week and 1 month. Cytotoxicity evaluation of the antimicrobial monomer DHMAI and DDMAI. Here initially the cells L929 mouse fibroblast cells are seeded onto 96 well microtiter plate. Afterwards DHMAI and DDMAI at 1, 2, 5, 10, 20, 40, 60, 80 and 100 microliters were added to the microplate and subjected to incubation for 24 hours. After 24 hours, MTT reagent was added to the plate and incubated further for 4 hours. After 4 hours, to dissolve the formed formycyl crystal, DMSO solution is added and absorbance was measured using multi-mode micropate reader at 570 nanometer, and percentage of cytotoxicity was calculated using the formula absorbance of the control minus absorbance of the test compound divided by absorbance of the control into 100. Coming to the cytotoxicity at assessment of modified PMMA resin, here in the first step sample preparation was done. DHMAI at 1 to 5 microgram per ml and DDMAI at 5, 10, 20 microgram per ml were added to the monomer of PMMA denture based resin and then mixed with the PMMA powder at powder liquid ratio of 2.5:1. On reaching to the Duff stage, packed into the Teflon disc mold to create a disc shaped 1 mm diameter and 1 mm thick modified PMMA samples. Discs were polymerized in a water bath for 7 hours at 70 degrees Celsius, followed by finishing and polishing and subjected to a cytotoxicity studies. Before the cytotoxicity assay, modified PMMA discs were cleaned ultrasonically in a distilled water for 20 minutes and exposed to UV light for 20 minutes to kill microorganisms and immediately subjected to MTT assay as explained above. Coming to the cytotoxicity evaluation of modified PMMA in artificial saliva, here disc shaped modified PMMA samples were placed in test tube containing 10 ml artificial saliva and incubated at 37 degrees Celsius. Later, at regular interval of time, 1 day, 1 week, 1 month, the incubating medium was pipetted and the cytotoxicity was assessed using MTT assay method as explained above. Coming to the antimicrobial activity studies, here 3 experiments were performed. Experiment number 1, zone inhibition test or agar disc diffusion test. Experiment number 2, direct contact test. Experiment number 3, FESEM observation. Standard strains used in the study includes Staphylococcus aureus, ATCC 25923, Streptococcus mutans, ATCC 25175, Candida albicans, ATCC 90028. Media used Muller-Hinton agar, MHA for S aureus, Shea blood agar, SBA for S mutans, MHA with methylene blue for Candida albicans. Quality control was done and done using appropriate antibiotic disc. Coming to the experiment, number 1, zone inhibition test was performed to assess the antimicrobial activity of DHMAI and DDMAI monomer. After the lawn culture preparation, sterile Whatman filter paper disc measuring 6 mm placed on the media and loaded with 10 microgram of DHMAI and DDMAI monomer. Later, the plates were incubated and diameter of the clear inhibition zone were measured. Coming to the experiment number 2, agar disc diffusion. Here disc shaped control and modified PMMA samples measuring 15 mm diameter and 1 mm thickness were prepared by compression molding technique and samples subjected to ETO sterilization and placed on respective lawn culture and subjected to agar disc diffusion test as explained previously. Coming to the experiment number 3, direct contact test or adherence test. Here similar standard stains were used. Media used is sheep blood agar, rectangular shaped control and modified PMMA sample measuring 10 into 10 into 3 mm prepared by compression molding technique and subjected to ETO sterilization and direct contact test was performed. Coming to the direct contact test, a loopful inoculum is placed on a test tube containing 10 ml triplet soya broth. Afterwards, PMMA samples are placed in the test tube. After 24 hours of incubation, the PMMA samples are retrieved from the test tube and washed with normal saline and placed in 10 ml NaCl test tube and subjected to vortex. And vortex was done for 1 minute and waited for 9 minutes. After 9 minutes, again 1 minute vortex was done and stock solutions are obtained. The obtained stock solutions are subjected to serial dilution from 10 to the power minus 1 to 10 to the power minus 3 microliter. Afterwards, 10 microliter of each stock solutions were transferred to sheep blood agar plates and incubated for 24 to 48 hours. After the incubation period, the colony forming units were calculated. Coming to the experiment number 4, addition of microbes to the test specimen was studied by field emission scanning electron FESA microscopy observation. Here, the direct contact test samples were retrieved, washed with phosphate buffer solution, then samples immersed in glutaraldehyde solution at 4 degrees Celsius for 2 hours. Afterwards, specimens were washed with the phosphate buffer solution and dehydrated using a ethanol 70, 95 and 100% for 10 minutes. Then samples subjected to FEM observations. Coming to the statistical analysis of the data, one-way or two-way analysis of variance followed by multiple 2-key post-hoc test at a 5% level of significance was performed. Coming to the results, this slide shows the cytotoxicity result of unpolymerized antimicrobial monomer DHMAI and DDMAI. From figure 9, DHMAI up to 5 microgram per ml and DDMAI 20 microgram per ml exhibited significantly decreased cell death as compared to control, indicating at lower concentration both the monomer DHMAI at 1 to 5 and DDMAI at 5, 10, 20 microgram per ml exhibited potentially less cytotoxic effect on L929 mouse fibroblast cells. At higher concentration, antimicrobial monomer presented dose dependent percentage of cytotoxicity except for DHMAI. DHMAI at 20 microgram per ml exhibited significant cell death. At 80 microgram per ml and 100 microgram per ml, DHMAI exhibited non-significant cytotoxicity as compared to control, suggesting DHMAI is less cytocompatible with L929 mouse fibroblast cells at higher concentrations. Coming to the results of cytotoxicity result of modified PMMA resin. Here, the graph shows modified PMMA exhibited dose dependent increase in percentage of cytotoxicity. PMMA with DHMAI at 1 microgram per ml, PMMA with DDMAI at 5 microgram per ml showed no significant difference in cell death, and percentage of cytotoxicity was comparable to that of DDMAI, suggesting at lower concentration DHMAI at 1 and DDMAI at 5 are cytocompatible and presented greater cell presented greater cell viability. DDMAI 10 microgram per ml shown significant difference in cell death. DHMAI at 2 microgram per ml and 5 microgram per ml and DDMAI at 20 microgram per ml presented highly significant difference in cell death, indicating its higher degree of cytotoxicity towards L929 mouse fibroblast cells. This slide shows the cytotoxicity results of modified PMMA in artificial saliva at regular interval of time. DHMAI at 1 to 5 microgram per ml, DDMAI at 5, 10, 20 microgram per ml has significantly reduced the cell viability and showed a significant difference in percentage of cytotoxicity at regular time interval as compared to control groups, except DHMAI at 1 microgram per ml exhibited non-significant cytotoxicity at the end of 1 month of interval. This slide shows the zone inhibition results of antimicrobial monomer DHMAI and DDMAI against the tested microorganisms. DHMAI at 5 microgram per ml showed significant antimicrobial activity against S. aureus, showing a zone of inhibition of 20 plus or minus 0.6 mm, whereas for S mutants and C albicans 18 plus or minus 0.6 mm and 19 plus or minus 00 millimeter respectively. DDMAI at 20 microgram per ml showed significant antimicrobial activity against S. aureus, showing a zone of inhibition of 19 plus or minus 0.6 mm, whereas for S mutants and C albicans 16 plus or minus 0 mm and 18 plus or minus 0.6 mm respectively, suggesting DHMAI at 5 microgram per ml and DDMAI at 20 microgram per ml produced satisfactory inhibition zones, indicating its higher antimicrobial activity in the media. This table shows the zone of inhibition test results of modified PMMA sample against the tested microorganism. Table 1 shows no zone of inhibitions were found around the control and modified PMMA samples against S. aureus, S. mutants and C. albicans. This slide shows the FESM image showing the adherence of microorganism to the test samples and control samples. Figure 13a show adherence of S. aureus in the control group. Figure 13b, C shows no adherence of S mutants on modified PMMA resin. Figure 13d and E show adherence of S mutants and C albicans in the control group. This slide shows the direct contact test result of modified PMMA resin. Table 2 shows no reduction in adherence of S. aureus was observed with both the monomer. S mutants completely inhibited the adhesion on modified PMMA containing DHMAI and DDMAI, and adhesion of C. albicans decreased in a dose dependent manner for both the monomers. Coming to the discussion, cytotoxicity study, residual monomer 0.2 to 0.5% may lead to mucosal irritation, allergic reaction, tissue inflammation, etc. Generally, heat cure PMMA contains lesser amount of residual monomer, hence there will be reduced cytotoxicity. Though in the present study a dose dependent percentage of cytotoxicity was observed, however, these values are within the cytotoxicity limit specified by ISO standard for denture based material. In the present study, added antimicrobial monomer in their polymerized and unpolymerized form presented greater than 70% viable cells, indicating its cytocompatibility with L929 cells. These findings are similar to the earlier reported studies. Antimicrobial monomer MDPB at 10 microgram per ml or less, MUPB 0.01 gram per liter, MAEDM at 10 microgram per ml, MHEHB 20 microgram per ml etc. presented cytocompatibility in respective cell lines. Antimicrobial activity. Antimicrobial activity of the monomer depends mainly on presence of positively charged quaternary ammonium salts with negatively charged iodine group, number of alkyl slide chains, length of the monomer. DHMAI has carbon 16 and DDMAI has carbon 12 chain length, can penetrate bacterial cell and break cell membrane, allowing cytoplasmic substances to seep out, resulting in bacterial cell death. In the present study, DHMAI showed significant increase in antimicrobial activity than DDMAI because of increased carbon chain length of DHMAI. These results are consistent with the few published reports. He et al. In the year 2011 showed methacrylate monomer containing quaternary ammonium with increased alkyl chain length from C5 to C16 has increased the antimicrobial activity. He et al. In the year 2014 showed quaternary ammonium based dimethacrylate with iodine anion with increased alkyl chain length from carbon 12 to carbon 18 has decreased the microbial activity of S mutants. Liang et al. 2014 showed quaternary ammonium methacrylate monomer with the increasing alkyl chain length from carbon 12 to carbon 18 has led to the highest antimicrobial activity. In the present agar disk diffusion study, modified PMMA showed the absence of an inhibitory zone. The reason, added antimicrobial monomer copolymerized in the polymer matrix, thus no antimicrobial component leached out to show any inhibitory effect against tested microorganism. These findings are similar to the earlier reported monomers such as MUPB, MDPB, TBAEMA and DMAEMA. Their addition to PMMA produced no inhibitory zones. In the present adherence test, modified PMMA samples have significantly reduced the addition of S mutants compared to S aureus and C albicans. Reason, S mutants has guanylate binding protein GBP and S aureus has enzymes such as proteases, nucleases and teichoic acid which can promote EPS growth in biofilm. Hence the monomer interfere indifferently with these proteins, thus the rate of addition and inhibition by the test compound has varied in the present study. Conclusion of the study, DHMAI and DDMAI can be potential copolymerizable monomer to impart antimicrobial activity to PMMA denture based material. Second one, incorporated DHMAI and DDMAI monomer has significantly reduced the addition of S mutants and candida to the denture surfaces except S aureus. Third one, addition of DHMAI and DDMAI monomer did not significantly affect the cytotoxicity of modified PMMA denture based material. Coming to the limitations of the study, Number 1, effect of monomer on the other types of denture based material such as rubber reinforced, hybrid, flexible denture based material has yet to be evaluated. Number 2, results of the present in vitro study cannot be extrapolated to the clinical performance of the material. Number 3, effect of increased concentration of this monomer on the properties of PMMA material has yet to be tested. Scope for future work includes evaluation of the long-term cytotoxicity effect of this polymeric material can be carried out, long-term stability and antimicrobial activity of these formulated materials can be tested, study could be extended to clinical trial after appropriate long-term preclinical validations, assessment of biocompatibility of this formulation using antimicrobial animal model can be carried out. Coming to the summary, adding quaternary ammonium based monomer DHMAI DDMAI to commercially available denture based resin significantly reduced the addition of various microorganisms tested. Adding DHMAI DDMAI to commercially available PMMA denture based resin did not increase the cytotoxicity. Overall, the result of the present study confirmed the suitability of DHMAI and DDMAI antimicrobial monomer as suitable additive for imparting antimicrobial activity to denture based resins. These are my references. Thank you.